Good afternoon, everybody. Hi, I'm Kristen Ahrens, and I am the project director for the Person-Driven Services Project. Today we have with us Estelle Richman, the former director, secretary for the Department of Public Welfare, now the Department of Human Services. And this is a follow-up to a session that we did a few weeks ago that David Gates from the Health Law Project conducted. And the point of these forums is really so that as a community we have a good understanding of what managed care for long-term services and supports might look like, and then that we're really educated about what person-driven services can look like within that model. So David's session was very much focused on sort of generally how managed care looks for long-term services and supports. That is available on the project website, which is on drnpa.org. I will put that up in the chat box so you can click to that and go to that. There's a 2-hour recording. There's also the transcript from that recording and a lot of resources to help understand the document that DHS has put out, as well as there's some information on other states and what they've done. There's position papers from a number of our partners in this project. So I would encourage you to go ahead and take a look at that website. And again, I'll put that up. I will also send out a follow-up email after this session with any of the links and any of the documents that we've been discussing. Just to give a little background on the Person-Driven Services Project for people who aren't familiar with us. The project we're in, we just started our 3rd year. We have 3 components: a demonstration, research, and advocacy. There are a number of collaborators on our project. The Institute on Disabilities, which is where I'm from. I'm the project director. Again, my name is Kristen Ahrens. Values into Action Pennsylvania is the support brokerage as part of the demonstration. The Mental Health Association of Southeastern Pennsylvania is also a partner, and again, they work on the demonstration component. Philadelphia Coordinated Healthcare works on the demonstration component. Disability Rights Network is our lead in terms of communication and our advocacy efforts. The Health Law Project is also a partner in terms of our advocacy efforts, as well as the Pennsylvania Mental Health Consumers Association. So there's a number of collaborators that work directly on the project. We also have a coalition of many organizations that have been involved in terms of trying to raise awareness and try to better expand and enhance person-driven options here in Pennsylvania. Our objective for our goal and for the work that all of us collaborators on our coalition does is all people with disabilities shall have the option to design, control, direct their own services and funding. So with that, I'm going to introduce Estelle, let her get started on talking through managed care for long-term services and supports. We will have time for questions. There's a couple of ways that you can ask questions. I think primarily what's going to be the best way to ask questions is if people can chat questions into the chat box that's on the screen. I will then read those questions to Estelle so she can address those questions as they come in. That's going to be the easiest way. For anybody on the telephone only, send me, if you can, you are welcome to text me or to send me an email with your question. I'll check those as well. With that, I'm going to turn it over to Estelle.
Thank you, Kristen, and thank you very much for inviting me to continue this conversation around managed care as it expands to include persons that have long-term support and services needed. Before I start, though, let me make 2 quick statements. First, I do not speak for the Commonwealth of Pennsylvania or for the Department of Human Services. And secondly, I'm just recovering from major surgery and still experiencing some pain, so if I look a little shaky, that's part of the reason. So. But as we start, and Chris and I are going to do a little different format after my initial comments. We're sort of going into a question and answer phase of this, which I hope will also spur some of your questions as we proceed. But first, let's review some of the primary tenets of managed care. First, Medicaid managed care is a joint project between the states and the federal government. Primary focal points are to reduce reliance on institutions, and this is all types of institutions, nursing facilities, state mental health hospitals, and state developmental disability institutions, but part of its goal was to reduce reliance on institutions. Secondly, it reduces reliance on high-cost programs, and your best example of a high-cost program is any inpatient service in a hospital, and to work very hard to find alternatives. Medicaid does provide treatment services and supports, all geared to providing those services and supports at the right time, in the right amount, in the right way. It should reduce duplication of services. It should increase prevention and promote wellness, and it should increase early intervention. All in all, if all of these things are done, managed care saves the state funds, which can be reinvested in other sources, in other ways. So the goal is to reduce reliance on high-cost institutions and to increase the availability of community-based services. Pennsylvania basically began looking at Medicaid managed care in 1986 through the Health Pass program, and proceeded in 1997 to Health Choices. Health Choices has two distinctive components. One is the physical health component, and the other is the behavioral health component. Both are now statewide. So Health Choices extends across the state. One critical factor to remember in Health Choices is that the Health Choices vendors across the state adhere to acute care and high risk. For example, they look at people with HIV, AIDS, people with chronic illnesses such as diabetes, people who have illnesses or accidents or some medical condition due to that. So it's acute. It usually has a point of time when it begins and when it ends, or it's gauged as chronic, and you know that it will exist over time. Going into managed long-term supports and care is a significant difference, because now you're looking at long-term supports, and traditionally that is not where managed care has been. So see it as a totally new service, at the base needing a lot of education and technical assistance to get off the ground. One of the things that has been evolving at the federal level for the many years after managed care has been HCBS, which means Home and Community-Based Services. And these are a series of waivers which can be used to keep people out of institutions or hospitals. And there are any number of them. I would tell you Pennsylvania, probably of all of the waivers available from the federal level, Pennsylvania had most. They were probably somewhere between 17 and 18 waivers before the Affordable Care Act, and Pennsylvania probably had 16 of the 17 or 17 of the 18. So they were, anytime a waiver became available to give us options of funding with Medicaid dollars, as opposed to having people in institutions who tried to take advantage of that. But one of the factors that was inherent in the community-based services program is they were not well coordinated. So you had 16 separate programs, sort of all functioning in their own little silo. They could be duplicative, so that they often overlapped in both eligibility and how they were operated. And there were still, despite the number of waivers Pennsylvania had, there were still populations left out. And there were still lots of other inherent problems in the program. Before I continue down this path, and before we jump to the question and answer session, I want to do some quick definitions. You will find that this is not only acronym heaven, this is also full of unique wordings, and it's in that unique wording that you sometimes have to pay attention. We've talked a little bit about Medicaid, and it is a joint program between the federal government and the states. Second, there's Medicare. Medicare is an entirely federal-run program, and the federal government, the Center for Managed Care and Medicare Services, basically runs the program. The Medicare program is for seniors 65 and over, and you find people often gearing their retirement to when they become Medicare eligible. Medicare also provides services for younger folks who have a disability. There are a group of people who are also what we call dual eligible, which means they're also eligible for Medicaid and Medicare. The Medicare program's contracts with insurance companies, usually within the area, sometimes nationwide, to provide those services to seniors and to people with disabilities. For people with disabilities, they are between the ages of 21 and 55. One of the big misnomers in both the Medicaid and the Medicare program, because the Medicare program is designed for people over 65, people often believe it pays for nursing facilities. That is not true. The nursing homes receive their payment through Medicaid, as opposed to Medicare. And while Medicare may have some small liability early on, it is a Medicaid-run program, and it's the most expensive, one of the most expensive programs that state Medicaid has to fund. But it's interesting how many folks believe that it is funded by Medicare. Just want to make sure everybody is aware that it is not. One other definition, and we've talked a little bit about home and community-based services. My other definition is about Olmstead. And one of the focal points for many states is how they implement or have an Olmstead plan. Olmstead is a Supreme Court decision regarding people with disabilities. Basically, it is a clarification of the Fair Housing Act, essentially saying that people have the right to live in the community and not in institutions, and that states have to be able to find ways to have people live in the community. And it goes pretty far, and rather they cannot mandate that states provide the funding, but the federal government is pushing states pretty far these days to try to make sure that people don't languish in institutions unnecessarily, and that states are producing options for people to live in the community. Another definition is the CILs. You'll often hear people talk about the CILs. And the CILs are Centers for Independent Living. They basically, as their mission, have to eliminate and prevent barriers that people with disabilities experience. They provide advocacy, information and referral, peer support, and skill training. It's important that folks understand the skills of what they do, because they will be one of the critical parts of any system that is developed in long-term services and supports. And one of the last definitions is, you often hear folks talk about the community first option. Community first option is important, but it is one of the many names for person-driven support services. We seem to have come up with a lot of different ways of describing that. Some of them are cash and counseling, community first, FDSS. Essentially, all of these essentially say a state needs to provide home and community-based services and support. This was established through the Affordable Care Act, sometimes known as Obamacare. It basically uses a person-centered plan based on functional need and it's based on people living in the community. So, as we begin to look more specifically at what Pennsylvania is proposing in long-term managed care services and supports, these are some of the words we'll be using, and it's important that we have some joint definition. Kristen, so we want to proceed to some of the questions.
Let's proceed. We did get a comment from Scott who said SILS are also now providing transition services from nursing homes.
Yes, they have been doing that for quite a while, and they have done an excellent job of talking to folks while they're in nursing facilities and pointing out the advantages of living in the community and help that make that transition. There are many people in nursing facilities today who did not or would not have chosen that as where they wanted to live, but they were given no other options in leaving a hospital, or they at that point in time could not go home for sometimes very basic reasons like steps. But once they often get into a nursing facility, they find it particularly more difficult to get back out. So the SILs have been very instrumental in helping people transition from nursing facilities to some level of community-based services. So thank you, Scott.
The first question is, in the simplest terms, what does managed long-term services and supports mean for a person who receives home and community-based services?
Okay. Right now, the state has in place contracts directly between the state, has a contract with the SILs, the AAAs, the agencies on aging, with counties and others to provide home and community-based services. These services range from treatment to supports in the community. They talk, one of the key factors of these services, even now, is quality of life, and how do we maintain and continue the importance of quality of life. So that's where we are now. Now, many of those services are not coordinated. They are not complete. They range in how they're provided across the state, which means some of the services and supports people may receive here in Philadelphia may be different from what they receive in Berks County, may be different from what they receive in Allegheny County. So you have any number of activities that can influence it. When managed long-term supports and services actually began operation in Pennsylvania in the fall or sometime within the next year, we are really looking at a better integrated, coordinated care. I think those words, both integrated and coordinated, are critical. It includes a focus that is much greater than acute care. If you remember, I mentioned that what the managed care entities do now is very focused on acute care. This will be focused on long-term care. This will be focused on the continuum of activities that go on in someone's everyday life. These will be support and services that begin the moment that people leave an acute care facility and begin to focus on the quality of their life and the kinds of supports they will need to maintain that quality. The service coordination component of it reduces fragmentation so that there is someone along with the individual who will begin to say, this is what I need and this is how I want it done. There's very much of a focus of person-driven. And while person-driven can have as many definitions as case management, they're still important terms to be able to communicate and work with. There's also a focus on transition planning and how do people leave one type of service and maintain their quality of living as they move to a different type. For the current recipients of home and community-based services, it really should mean better integration, better transition, and better service coordination. It really should stop operations in silos. It really should begin to do something I think we've all looked forward to, which is an integration between Medicaid and Medicare. And it should have a major focus on quality of life. And the quality of life, as I define it, would be the person themselves first defines it, and second, that person directs it. It's hard for me to tell you what your quality of life is, what's important to you, what's meaningful to you, and what's essential to you. You can tell me those things. I can work together and being able to make sure that we get as close as possible we can to meeting your standards and your ability to have that. This is one of the programs that also has because we're getting new, and even the states that have introduced managed long-term cares and supports are still new to it. The oldest of those states, I think, started probably only about 5 years ago. Everyone is still feeling their way to make sure they understand what it means and how to do it and how to do it correctly. To me, that means there has to be some level of flexibility. We learn from our mistakes, we continue to fine-tune, and we continue to be able to look at how we ensure on a consistent basis that people who are within the managed care plan have control.
Do you have any recommendations for sources or resources that provide measures for quality of life? Do you have any suggestions for what people can look at that would provide some guidance around how do we measure quality of life, and in a new system, what should we be looking at?
I don't have a specific media that I can direct you to, but I would say the best way to determine quality of life is talking to individuals and asking what would make their life, in their own words, work better for them. And what does it mean to them, and what would they like? Is it having choice over, it could be as basic as having choice over what they eat or where they go, or having the ability to be able to make their own decisions. You know, I spent the last several years of my professional life working at HUD, Housing and Urban Development, and found out people had lots of different things they wanted in their housing. But one of the very basic is they wanted to hold the key to their own apartment. They even if they lived in a rooming house or a boarding house, they wanted a key. They wanted to be able to feel that they had control over their living space. And that's pretty basic for most of us. We really, but you probably will not be amazed how many people don't have that. So I would start by talking to individuals. What does quality of life mean to you? And how do we help get you there? I'm sure if you were in today's world to Google it, you would find tons of definitions. But all of those definitions are going to be somebody else's quality of life. Which is why I, again, tell you to start with the individual themselves, either talking to them or more appropriately listening to them.
I think you really make a good point to make life easier in the home. And deaf people has experienced is for communication. They're hearing people are not communicating. They're not bringing in an interpreter. And they really need that for quality of life. And I think that, having that communication at home be provided. My friend is now gone because that was taken away from our home because of the lack of communication for 11 months until she passed.
The question was, people who are deaf and hard of hearing cannot have quality of life at any level if there are not interpreters or ways for them to communicate with their peers and with other people where they live. My answer to that is you're 100% correct. And I would expect that any managed care plan that is providing services to people who are deaf absolutely needs to have in the home accessible 24/7 communication, so that person never feels isolated and never feels that they cannot communicate or have the ability to communicate anytime they want in 24 hours. In other words, if we wake up at 2 in the morning and we want to chat, there is someone who can help us do that. I know that may be tough for managed care plan to hear, but that's part of the responsibility for helping people live quality of life.
So the next question is, for this group's perspective, what we're really interested in is how can we have the best person-driven options or consumer control possible? What is sort of the extent of what Medicaid will allow under managed care? Can people still hire their personal assistants? Can people still hire a respite worker? How are they going to be paid? How is the budget going to be determined? So if you can talk about sort of from the maximum extent of consumer control that Medicaid would allow, so that for everybody on this, we have a sense of what's realistic to be asking DHS to include in the proposal.
The nice part of this is CMS, which is the Center for Medicaid and Medicare Services at the federal level, has made it possible that the answer to almost all of those questions is yes. Yes, they allow it. They do. They allow it. They have mechanisms that can be worked out. They include a discussion in many of their papers around what is called FMS, which is financial management services. They permit personal assistance. They permit respite workers. They permit consumer payment of those, and the consumer to be the employer. They permit consumer budgets. They basically permit it all. It's not in can you do it. It is in how you do it. So that what they're going to want to see from the state, when the state does their final waiver, is how is the state going to ensure that people have access to these services in a way that fits the Pennsylvania waiver. Now, Pennsylvania can choose, it's a little bit like a laundry list, can choose what to include, what not to include, how to include it, what's basic. Some of that is going to be in the responses to the RFPs and how creative they can be. But what all of us, and I basically say us on this, since I am 71 years old and could be at any point eligible for many of these services, what do we want to see and manage long-term care and supports, particularly for those of us who want to make sure that we are not in an institution and can spend our time in community-based services. So we want to continue to push the state, and I can tell you when I was secretary, I encouraged that, to be able to provide for people, no matter how disabled or ill they may be, to have options in the community. But it's very much voicing your concern over and over and over and over and over again. I would tell people, no, I don't take no as an answer. Find another way to push your question. You may get no, but that doesn't mean you have to accept it. It also may mean that you need to also suggest alternatives. But the reality is that this is also a system of accountability. This isn't a level where the state just throws money at a problem. There has to be some level of accountable because they are public tax dollars. These are all of our dollars. Any of us that pay taxes are funders of this. So we want to make sure our dollars are used well. We want to make sure these are providing for quality of life, but we also want to provide that people don't get over their head. And that if someone is going to choose to be a consumer employer, that we're giving them the supports they need, that we're educating them on what is and is not good practice, that we give them that help and support as they request it, and that we help them be the kind of employer they would like to be. If they choose a different model or a different budget or a different mechanism, we also want to make sure they understand the option they chose. We want them to understand how to get a coach if they need that to help them. But we basically want as much of this to be in the consumer's hands. We will always, the state will always, as a state entity, be concerned around fraud, abuse, and bad decisions. That is part of their responsibility. But in response to that, they can also provide help, support, coaches, education, training, and have just as many options and tools to be able to help. Key to all of this is individualized budgets and individual personal service plans. So not only are we talking about structure, we're talking about structure that can be maintained by the person and is signed off by the individual. In some ways, I know this is an awful lot easier to talk about than to do, and the devil always lies in the operations. But I would also tell you we all need to be vigilant, and we see something that isn't working, or we see something that we think needs to be improved, that we let someone know. I will also share that as a state secretary, I had no magic ability to know what you were thinking. I didn't read minds well, and I didn't know things that people didn't tell me. So I always ask folks to, if you see a problem, it's sort of like they're saying now about our safety. If you see it and you don't think it's right, talk about it. Tell someone. If you see a problem, let us know and make sure that it gets up to the right level. If you feel you're being intimidated, let someone know and let us begin to develop a plan around it. But whether it's me as secretary or any of the secretaries before me or after me, I can guarantee you none of us read minds well.
Who is going to educate the MCOs about long-term in-home services? Can consumers have input?
This is sort of what I call reading the crystal ball. Yes, there does need to be education and training. I would tell you that a major component of that education and training should be consumers. And I'm using consumers right now in its purest form. That means people who are receiving services. I do believe there's a role to what I call secondary consumers, which means their parents or caretakers. But I think that consumers need to be part of the education and training. I think education, and if I were running a managed care company, I would find a cell or a group to contract with to come in and work with my staff, to come in and help consult with me around the response to the RFP. I would put them on staff and I would keep them as close to me as CEO as I possibly could to learn as much as I possibly could from them. I would recommend to the state that they do the same thing, that they have a large, not necessarily huge in number, but they have a group of consumers that do the same thing, that work with them, that begin to educate the state staff, both at the broadest level in DHS and at the more specific level of the Office of Medicaid, OMAP, of Medical Assistance Programs. I think there's nothing that's going to substitute for education and training, and the education and training that is needed is best done by people who live with the challenge every single day. No one is going to understand the isolation of people who are deaf other than people who are deaf. And they're going to be the best trainers to be able to do this.
Under Medicaid managed care for medical services, there are clear standards for the adequacy of the provider network. For example, adequate number of doctors, labs, and hospitals. As a parent, I personally know that within the HCBS waiver programs, there are gaps in services and an inadequate access to services. How will managed care within the home and community-based service waivers ensure an adequate provider network?
You're right. There are standards set in the Health Choices program. I would tell you there also need to be standards just as tight, just as stringent in the managed long-term care and support services. It is up to the managed care companies who respond to the requests for proposals to describe how they're going to assure that the services are available and available within the time span. It doesn't help just to say they have to be available. They have to be available within a given time span as they are within Health Choices. And I would say to any plan who doesn't have a way of understanding the significance of this, they need to talk to consumers again and why it's important. So yes, you are right, the standards are not there. And one of the reasons for going to a managed care format is to get those standards in place and hold people accountable. Again, my own opinion, one reason a managed care program can be successful or it can be a disaster is how the state monitors the program, and does the state hold people accountable for observing all of the standards that they set up. In other words, if I say someone has to be seen within 48 hours for a routine visit, and I get a series of issues that tell me people are not going to be paid and I do nothing, then that's the state's problem. That is not the managed care problem. The state said 24 hours or 48 hours, and they have to hold people accountable for that. I would see the state setting the same standards and holding people accountable.
Can a policy be established that no deaf person is to be removed from the home until the person has a sign language interpreter at all stages of life-changing placement decisions?
Yes, I mean, can it be? Sure. That should be a policy. Whether they will establish that as a policy is up to the Department of Human Services and the people who make those decisions. But should it be a policy? Yes. Will it be a policy? I can't tell you.
And when we're talking about effective communication, it's essential. If not, then the case should be closed.
I agree with you, but I'm no longer making policy.
That's what happened to my friend.
You're right, and there's no excuse for what happened to your friend to have happened. And what I recommend is we do as much advocacy as we can to hold people accountable.
There have been a number of questions asking essentially about the populations that DHS intends to include and which home and community-based services. So the question is, will managed care include all home and community-based services, OLTL, ODP, the ID waivers?
At this point in time, from the information that I have read, it does not include the ID waivers. I have read nothing that tells me they are planning to include the ID waivers at this point in time. The only thing I would add is that they also look at two of the waivers that are similar to the ID waivers but not always classified as ID waivers, and that is the ComCare waiver and the Oprah waiver. But at this point, I have read nothing and talked to no one that would lead me to believe that the ID waivers are included in this proposal.
Then there's a number of questions that are related to people using agency services versus consumer control and combinations of those. So in managed care generally, can a state allow people to do both, direct some services and use agency services? And is there anything in the state's proposal that gives you a sense that they're planning on doing one or the other or both?
I think, one of the double-edged swords within the white paper is very good that they left it open. So they didn't make decisions or even hidden decisions. They've left it very open to listen to all ideas. The problem is when you leave it open and leave it to all ideas, then you tend to get groups that think that means everything is a no because there's no structure in it at all. So I try to read it that the state is really open and that they are not going to choose whether or not it's consumer directed or agency directed. I think they're going to make sure that the plans are capable of doing both. I think that they want to, it's what I call the most creativeness of the proposal and the ideas. Let's see what people come up with, understanding that for some people, self-directed services, including the consumer as an employer, the consumer as the budget person, are critically important to them, and they really want, and they are capable, and they want to have that control. On the other hand, there are other people who say, I'm really bad at that. I don't want to control all this stuff. I'm 70 years old now. I want someone else to manage that. I just want to make sure the person fits with me, cares about me, and can take good care of me. But I don't want to have to figure out budgets and paychecks and hours. That's just not what I want to do. We have to accommodate that too. And I think that if we're listening, what we hear are people who want an individualized, person-centered plan, which means this is what fits for my choice. It may be very different for you or for you or for you, and the plan needs to be individualized to accommodate that. I would tell you that parallel in health choices would be services for children under EPSDT, where every child was entitled to an individual service plan that focused on their services and their family. And it took a great deal of effort for both the behavioral and the physical care plans to come in with those individual ways of handling that child's behavior problem or physical problem or medical problem. And I think this is going to take both creativity and a lot of support for the plans to both understand it, back to education and training, and to put together a plan that demonstrates it.
So you had talked about sort of person-centered planning. Can you talk about how person-centered planning happens within a managed care model? And then a lot of the questions that have come in, there's a number of questions around service coordination and what that looks like. Does someone have a service coordinator for behavioral health? Do they have a service coordinator for their home and community-based services and then for their acute health care? Or is there one service coordinator that's going to be doing all of that service coordination?
You're probably going to have to remind me of pieces as we go through this. A person-centered plan is not, in the way that we define it in the world of long-term care, does not have a true counterpart in health choices. It has types of person-centered care, but not at the level that we're talking about in services of support as opposed to medical services. I do think that is a place where, again, education and training about what a person-centered plan, because again, we're talking functional as opposed to medical. And those are different. And again, I'm not always sure people understand the difference for a medical plan looks at your medical functioning. A functional plan looks at how you live your life and whether or not you're having functional, whether you're having choices in life that give you to an ability to choose how you live and the quality of your life. A person-centered plan helps you get to your functional quality of life, which is what long-term care services supports are about. I don't think there's a good, there are some counterparts, but I think this is an area where people will really need some education and training. And I hate to go back to that again, but the question did come up. I think it was a very appropriate question. And I think that we need to focus on how do we provide it, where can people get it, and put down the basic tenets of quality of care. Now, I try to think if I were trying to plan, do a person-centered plan, what would be essential? Part of it is I would want to make sure I had good assessment. In other words, people knew exactly what I was capable of doing and what I was capable of doing at my baseline level plus where I wanted to be, and how I got there and didn't lose skills that I had. I would want people to make sure that all of I think communication, whether it is communication because I am deaf or communication because I have a hard time articulating what I want and what I need, both can be accommodated. One is I'm deaf and I cannot hear you. The other one is I hear you but I don't understand you. And I would want to make sure there are mechanisms for both of those. I would want to make sure that I did not have to interact with 2, 3, 4, 5, or some other outrageous number of professionals who are designing my care plan. That there really is one person who is accountable for that, and that person coordinates with the other people. And can actually have that level of communication skill within themselves to make sure that whether it is the people that either providing or helping me with my housing, in other words, paying my mortgage, whether it is people who are arranging for me to have transportation or for me to have to get to my job or to get to physical therapy. I don't want to have to deal with 5 different people and schedule how all those 5 different people meet together to figure out what's going to happen. I want a plan coordinator who really has the ability to talk to me, understand me, and then work with that other group of professionals. That's very difficult. I actually tried that in a couple of different ways when I was at DPW and never found a way to get professionals to talk honestly together. So I know how difficult it is, but I still think it should be a goal, and I also believe it can be done.
There was a couple of questions that came in that refer to our currently overburdened service coordination or supports coordination, and whether this system is just going to replicate that, or within managed care and with other states' experiences doing this, is there a way to make that a less burdened position so that people really have the ability to do good care planning and care coordination?
Well, I think there's a way. I'm not sure I can articulate that, but part of what makes it difficult sometimes are one, people are carrying too large a caseload, so they don't have the time. Secondly, they are not giving the other supports they need. In other words, they may need aides to help them with the job, and they should not be expected to do every single thing all by themselves. Third, they're often underpaid, so that they're feeling very burdened themselves. And fourth, they frequently have not received good health care for themselves. So it's hard to be consistent if you are worried about your own abilities to survive. I think all of those should have some response. Caseloads, I think I see caseloads as one of the more critical things in terms of some of the activities will need a lot of focus and a lot of attention, and a lot of time, and we should not expect these individuals to be Superman or Superwoman. We should expect them to also have normal lives and be able to do that, which means if they have on their caseload 5 different individuals for whom they will need to spend somewhere around 15 hours a week, that doesn't work. It takes math. Don't make them fit into something that's not doable. And don't give them caseloads of which people need high individual attention without other kinds of supports coming in to help them. I think this can be done. I think it takes smart people sitting down with consumers and with SILs and working through it. I don't think it can be done on the fly. I also think it can be a challenge, but I do believe it can be done.
I do want to give a reminder to everyone who's on the webinar that Estelle does not work for the Department of
Right.
Human Services.
That's right.
She did not, this is not her discussion document. So there are a number of the questions are asked in such a way as if Estelle is speaking for DHS, and she is not. Estelle is here because she has a great deal of expertise around CMS rules, around managed care, around what other states are doing, around person-driven services, which is why we invited her. But I just want to let her off the hook, for she is not answering for DHS and does not make DHS policy.
I'm not answering for DHS. I do not make DHS policy, and I am not advising DHS. I am not on their payroll, and I am not in an advisory capacity. So when you ask me a policy question, I can say I agree, but I have no status.
Yeah. Yeah. So that's for everyone out there. Just wanted a reminder.
So who do I tell that to then? Who do I need to pen?
So the question was, who do we tell that to then? Toward the end of this, we will give you the information again. Comments are due to the Department of Human Services on their discussion document, so on their sort of proposal for the managed care. Those comments are due tomorrow, by the end of the day tomorrow. So there is an online form that you can fill out. I believe they also give a phone number and an email. Before we end, I will make sure that everybody has that information again.
Great.
It is also up on our website. But the comments, DHS has requested comments. They want input from people about program design, about implementation, about quality, about monitoring. So we will make sure you have that information and can get your comments to the right people.
And I would strongly recommend that you take advantage of this opportunity to voice your concerns and to make strong statements about where you think potential problems could be.
And we have, and I can send this to folks that are on the webinar. The Person-Driven Services Coalition has put together some comments. I have them in draft. Hopefully we'll have time at the end. I can share with you what our comments, the recommendations that we're going to make, what those are, and those are, again, very specific and very directly related to the sort of program design to allow for the best options for person-driven services. So the next question is cash and counseling possible within the managed care model? As people know, Pennsylvania we have a very small cash and counseling model. It's within the aging waiver and the attendant care waiver, and it's called Services My Way. It is not used very broadly. There's only, the last data I saw, there were about 34 people in the state that were using services My Way, but we do have this cash and counseling model available statewide. And that is a model from the work that we've done in our coalition that people really like because it offers the greatest amount of control. So, we're concerned that it hasn't been more widely used. We want to make sure that it's in any kind of new option that the state is proposing. Can people have budget authority and use their budgets flexibly? What might that look like, and what can we do to make sure that that gets in there and people really have the option statewide?
The cash and counseling program in Pennsylvania has not been widely used. There's nothing about the counseling and counseling program that would prevent it from being part of a managed care program. In fact, it would probably be a good model. I would almost wonder whether or not the folks who will respond to the RFP know about the counseling going on in Pennsylvania and where their knowledge base is. But it is one of the things I would look for in a response, in that how would they implement it. I think it's one of the better models. It really is about choice and control. It really is about people who want to have that control and giving it to them. And whether they are able to do it totally on their own, whether they're able to, whether they need a coach or support in doing it, how those financial management services are done is critically important. And for any of us, how we get paid or how we pay our attendants or our caretaker is critically important. And I would believe that this is the best of person-driven support services, or Services My Way. There are 3 names to it. And the real issue is, can the NCOs present a model that recognizes the importance of consumer choice? Because I would say this is one of the gold standards for community choice, and would hope to see it. So there's nothing that precludes it, nothing that says that it can't be done. I would again say to people who are interested, I would not only make sure this is in the response to the state, I would make sure I say it several times.
So the next question was, could Pennsylvania offer supports broker services to people in managed care, and how would they do that? Again, yes, they could. They just have to, support broker is an acceptable alternative within the Medicaid program. So again, yes, they could offer it. They have to determine under what basis they want to offer a broker services. There are a lot of rules around broker services to protect the interests both of the individual and to make sure there's no fraud and abuse. But again, I think it's a great standard for managed long-term care support and services, and would like to see Pennsylvania go in that direction of offering those broker services. Broker services, again, are a little bit more complicated, and I think they will need a very clear financial management services understanding on how to operate it. I think they will have probably need a little bit more depth in their education process around making sure people understand both the risk and the positives around broker services. But I would definitely, hopefully, that people would strive to include it within the managed care format. There are several questions that have come in related to people who are dual eligible but not on an OLTL waiver. So for people who are dual eligible, so they have Medicaid and Medicare, and they qualified for an ID waiver, what will happen with those folks?
I will say again, there is nothing that I read in the white paper that would lead me to believe that this impacts the ID system at all. In other words, the people in the ID system will continue to receive services, supports, waivers, health choices, you name it, they receive it in the same way they're doing now.
Okay.
There again is nothing in this plan. I basically do support that. I believe that ID at this point needs to maintain a total carve out from long-term managed care.
There have also been several questions around how people can opt out. So there have been questions about individuals opting out of, so people who qualify opting out. There is also a question about how can the OBRA waiver opt out. So if you can address those.
Typically the only way that you opt out of a managed care plan is that it's written into the original waiver from the feds to the state, to the feds. In other words, when they describe who's eligible, this would be either a group they describe as not eligible or a group that they describe doesn't meet the eligibility qualifications for it. There is usually no individual opt-out in a managed care plan. But the state can look at who's in is described through how the state writes the waiver. Mm-hmm. And they can put as much or as little detail in that as they want. I would recommend they not leave it too vague because that doesn't help people understand who's really eligible for it. But it is basically all part of what the feds approve for it. And then once the feds approve it, you can make changes into it afterwards. They just take more time and they are pretty problems. So this is the opportunity that the state has now, is to be as clear as possible. It's still highly likely that the feds will come back with questions and want to know why you excluded this group or why you didn't include another group. Pennsylvania has traditionally been inclusive and put everything in. Carving something out would be a little different road for Pennsylvania, but I do believe that that particular waiver may be one they want to look at again.
Couple more questions on service coordination. How can we ensure that intake and case management are independent from the SC or the MCO?
Case management and
whether case management being independent of intake for intake and case management from the MCO.
In other words, I'm trying to figure out, are you talking about enrollment or are you talking about once people are enrolled?
I'm going from the question, but why don't we talk about that structure, sort of what could or should be independent from enrollment, intake, and service
The
coordination.
enrollment broker, the person who helps you decide what plan you're in, has to be totally separate from the MCO.
That's a CMS rule?
Yes.
Okay.
Yes, totally separate. You cannot have any interaction. It's because in the early days of Health Choices, it may have been just Health Pass, I don't remember whether it was Health Choices, but I think it was Health Pass, not Health Choices. The MCOs could recruit you. They could basically say, do you want to be in my plan? And by the way, if you choose me, I will give you a toaster, a baby, a chair, I can give you things to attract you into my plan. By the time Health Choices started, it was no contact. It has to be a totally impartial choice. I give you the facts, you ask me questions, you make a choice. But the MCO cannot enter the room. that will be the same thing on this one. The enrollment broker has to be a total conflict free. But so I wasn't quite sure whether this was the enrollment broker or the term case manager has so many different definitions. I just wasn't quite sure.
Mm-hmm.
If they're saying that all managed care plans have someone in that plan that is accountable for that client, to make sure that client is getting the things they need, that client is, that standards are being met, that the quality is being met, that person isn't necessary, that is not the same person that is your person-centered plan coordinator.
Mm-hmm.
So you want the plan to have people accountable, that they can hold accountable for making sure someone called and said, did you get the service? Was the service to your liking? Did it meet your quality? Did it come within the timelines? That's what the people in the plans do. When the doctor said he would see you within 24 hours, did he offer you a time within 24 hours? So you have that accountability. On the other hand, that person who wants to make sure that there is a plan is not the person who does the plan. That person should be independent from the managed care organization. That person often gets called a case manager too. But that's an individual who basically helps develop the person-centered plan. What is it that you need for your quality of life, for your standard, for your care, and how do we begin to put that in action? So, to make sure those things happen, I think we both said and will continue to say, people need to make sure they send comments into the state. If they haven't, they have until tomorrow to do that. They need to take every opportunity to communicate with the state around this. When the plans begin to write their responses, people may want to make themselves available to the plans as someone who would be willing to coach the plans or talk to the plans, and say, if you want to talk to people who have a disability, I'm willing to be one of those people, and I offer my availability to you. So I think that just because the state at this time is saying this is the deadline for our comments, it doesn't mean that all interactions should stop. I believe and would recommend highly people continue to write letters to the state around their concerns. I would recommend that people continue to communicate to the CILs and their local CILs around their concerns. I would recommend that people continue to talk to advocacy groups around their concerns and their issues. And all of these are still doors that can be, that are not closed. I would tell you, I would be remiss if I didn't tell you, CMS, the regional office, always takes comments also, and will probably take comments throughout the process. So I think that people who have particularly very concrete issues and they are very concerned about them, they continue to make their voices heard.
Several questions are around sort of choice of MCO. So there was a comment in Southwest PA. We have a split between two very large HMOs, and the question is, will managed care cut in half our options for care? And then there was a couple other questions that were, will I have a choice of MCO, given the state's plan, or am I going to be locked into one MCO?
You will never be locked into one MCO. That's a federal rule. You will be given options, for example, when we were making decisions about health choices in the Southeast, we made a decision that we wanted to have a minimum of 4 plans in the Southeast. the 5 southeast counties that people here typically are in. We did at one point have 5 and 2 merged, so we have 4. But we didn't ever want to go below 4 choices, so people have 4 distinct choices. My assumption would be the state will try to have some level of a policy around that they will always want. I would say they want at least 3 in every zone. The southeast zone is the largest of the zones, so to have 4 made sense. But you want to give people a choice of at least 3. And sometimes, it all depends on how many people apply. You know, if you only have 2 people applying to be the managed care entity in an area, the choice the state has to make at that point, the decision the state has to make at that point, do you go with those 2, or do you re-offer the RFP to see if you can attract in one other? I would want to keep the numbers up.
There's also a number of questions that are around, I would say, around concern of losing services and health benefits. So a question, the one specific question was around if somebody currently has 24/7 service and support right now, long-term services and supports, will they be able to get that in a managed care model? Other questions about expectations for losing prescription coverage or other specialty coverage under a managed care plan.
I would categorize those are all operational questions. That, as people describe it, they should not lose service. You know, I will throw in a reminder here. I'm not an employee of the state. I don't have any status that will allow me to make any decision along this line. I do have, as I will tell you in the end, several recommendations for the state. As you have recommendations, I have recommendations for the state. And one of my strongest recommendations I've sort of phrased as do no harm, which is if people are receiving services now, living in the community and thriving in the community, we should not touch it. Should not take it away, should not remove it, should not do harm. And should try to do as much as we can to make sure those stay in place, up to the point of considering that a policy.
Are you aware of other states that Pennsylvania is looking at or modeling this plan after?
No, I'm not privy to that information.
Okay. Are there, in terms of this group thinking about good sort of design or implementation, are there states you would recommend that people take a look at?
There are several states, somewhere around 3 or 4 perhaps, that have been engaged in managed long-term services and supports long enough to actually have a track record. I can't name them off the top of my head. If they know to get in touch with you, Kristen, I can try to get that information. I would recommend that folks either talk to someone in those states, and again, I would recommend they talk to some of the consumers in those states to see how the services have functioned. But long-term care, managed care, and in the early days of health choices, some of these same conversations were going on, and people were scared to death. They thought they would lose things. They thought the world would come to an end. They thought that people would be unnecessarily harmed. They had great fear, and the future was unpredictable because we hadn't done it in that format before. I would tell you, 5 years later, 10 years later, and now 17 years later, if I told people I was taking health choices away, they would probably come after you with a posse.
Right.
Because they don't want to lose the services they have and go back to an uncoordinated fee-for-service system where they weren't sure they could find a doctor or not. There are all sorts of bugs in a managed care system when it starts up. My hope is that the state will learn from their errors and for each region begin to correct for those errors and learn and do better. And it's through that way we get to a plan that actually does what we want it to do. They have a rollout plan, and this is going to be one of my other comments. They have a rollout plan, and I have no problems with the rollout plan, but I do have a problem with one RFP. Because one RFP doesn't give you the ability to learn from your mistakes.
How does, and if so, how does the final rule impact this process, the managed care organization?
Not quite sure.
I think this question is around, I'm guessing around CMS's final rule on home and community-based services. And I'll take a shot at answering this, which is that anything that the state proposed would still have to comply with those, I would imagine, would have to comply with those rules. Those are the rules for home and community-based services, and they apply to, we don't know what kind of waiver DHS is applying for. They haven't said in their proposal whether they're applying for an 1115 demonstration waiver, or they plan on doing, some states have done what's 1915B, which allows for the managed care, and then they manage their 1915C waivers, which is what we have now. Some states do that. So it depends. Some of this depends on how DHS decides to do their proposal. But I would think in most cases the rules around home and community-based services are still going to apply.
Question, could you explain that for some of us that don't know exactly what that means?
So there was a question to explain what I just said about waivers. So currently the Office of Long-Term Living waivers that we've mostly been talking about today are, the attendant care waiver, the aging waiver, the ComCare waiver, the independence waiver, and the OBRA waiver. Those waivers and the AIDS waiver, those are all under the Office of Long-Term Living. And those programs all, for people who qualify, so they meet some kind of eligibility criteria, they meet the age criteria, and they have Medicaid, they meet the income criteria. They are then eligible to receive the services that are outlined in that waiver. So specific population of people can receive a specific set of services, and that's our agreement with the federal government. Those are called 1915C waivers. So Pennsylvania could choose to use managed care to operate those same kind of waivers. But another route that a number of states have gone is to use what's called an 1115 waiver, which is, these are numbers that refer to Medicaid rules. And the 1115 waivers are what are called demonstration waivers. So states have a little more flexibility and leeway in terms of the design and what they're choosing to do. So, and Estelle, you probably know better than I do how many states have gone the 1115 route versus the other route. And then there's another...
and there are usually reasons why states make the decisions around what kind of waiver they want. And I used to know all of that and know the reasons, but no, I don't.
Yeah. So and people, I'm sure DHS would also be happy to hear if people had strong feelings or comments about which of those Medicaid rules would best serve Pennsylvania. When David Gates did the presentation for us a few weeks ago, he was also talking about another Medicaid authority, which I think is like the 1905 A or B or something. Please go back and watch that if you want more information. I'm not, that's not my area of expertise at all. But David did get into sort of all of the different ways that Pennsylvania could go in terms of our agreement with the federal government for how we're actually operating these. But regardless, I think some of the things that we're really interested in is making sure that there's the full continuum of care in there, including really robust person-driven services.
Right.
People should have the ability to have an individual budget that they can use flexibly. They can buy goods and services that are not specialized, that are not medical in nature. That people who need support to be able to do that, have that support. We like this role. Our coalition really likes the role of the supports broker. So somebody who has expertise in helping people use an individual budget and figure out the best blend of paid and unpaid services, help people find those informal supports and coordinate them. For people who are managing their own personal assistance workers or their own community integration workers or respite workers or supported employment workers, whatever those people are that they're actually managing as the employer, that if they need help to do that's available to them. So those are some of the priorities of our Person-Driven Services Coalition. That is all included in the benefit package and the design of whatever DHS ultimately ends up putting together. And I know there's so many questions that come with this proposal, because we are talking about physical health care, we're talking about behavioral health care, and we're talking about the long-term services and supports. So it's so many layers of complexity to really think through. I would encourage people to take a look at the Health Law Project just put out. They've got some draft comments that have been circulating around what they think should be in terms of the implementation and what's kind of included in the program design. They've got some very extensive comments. I'll share before we end today. I'll share our recommendations from our coalition that are still in draft, but I think we've got kind of the core of what's going to be in there. So Estelle, the last sort of big question for you is, in your experience and with your sort of national perspective, can you talk us through the things that we should be concerned about in terms of the any kind of change to manage long-term services and supports? Again,
based on my having worked within the system at different points for over 40 years, I think there are some things that I have learned. One of those is that I think managed care, if it works as it is designed and enforced as it is designed, works on behalf of keeping services coordinated. It keeps people out of institutions. Mm-hmm. It gives people more choice, and it coordinates services in a way more effective than a fee-for-service system. I think managed long-term care will very definitely work to keep people in home and community-based services. I think they will focus on integrated and coordinated care. So I think we will have fewer people who are not receiving attention in the system. I think they will understand that the focus is on quality of life and functional stability, as opposed to acute care and short-term stability. I think it will reduce the fragmentation of the system. And I think it will add to an individual's ability to transition either out of an institution and away from institutional type care into the broader world of having their own needs and services met. And I think that Pennsylvania is capable of this. Our managed care system is the word we often used is mature, which means it's been around for a fairly long period of time. Health Choices will have its 18th birthday, I believe, in next February, which means that it's performed well over the years. I think there are a lot of things that have been learned. My hope is that the things that we have learned will inform the current Department of Human Services to write an RFP that I think recognizes the fallacies of the current system and works to correct those. I think this will be a way to rebalance the long-term care system in Pennsylvania. At this point, we have more people in institutional settings than we have in home and community services. We also know that for everyone in home and community services, for everyone in a nursing home, we can serve somewhere around 2.5 to 3 people in the community. So it's better use of taxpayers' dollars. And we know that our long-term care system is going to be gradually but steadily overburdened as the baby boomers require more needs. So being able to look at this now, to get it off the ground, to do sort of a work to make sure we correct the problems we find in the system now, I think will prepare us well as we see the largest number of baby boomers coming into the system over the next 10 to 20 years. So there, in any way we do this particular activity, I see it as being good for not only Pennsylvanians who have disabilities, I think it's also good for Pennsylvanians who are taxpayers. I think this is the right direction to go in. With that said, I still think there are a lot of issues that are going to come up over the next several months where DHS will have to make decisions that will be critical to how well the program functions in its early years. Some of those I think we learned from the implementation of Health Choices. Some of those we've learned over the last 17 years around operating a program. And my advice to DHS would be to pay attention to several things that I think could be potential landmines. And these aren't that I think they're going to blow up on them, but I would strongly advise they go back and look very, very carefully at these several issues. One is the timeline. As I said, I don't have a problem with the rollout timeline, but I believe one part of what I read is that they would issue one RFP and then have that one RFP guide all of the timing of as they roll it out. I really would roll it out, and for each area they're rolling out, use a different RFP and what they learned from one and build into the other. So if we found out that we really wish we hadn't done it that way after the first one, we have an opportunity to fix it in the second. If there's something in the first two or something in the second that worked well because of the part of the state they were in, but we don't think it's going to particularly work well in a different part of the state, we have a way to correct that. I would never short myself on the opportunity to learn and to be able to fix something at that point in time as we move through it. It goes back to one of my favorite mottos from a book called In Search of Excellence, which is called Ready, Fire, Aim. which means you do ready, you get prepped like you're doing now, you do it, and then you debug it. I think there are going to be things they learn from that first rollout that they didn't know beforehand that they will want to correct, and they should leave themselves that opportunity to be able to do it. And while maybe they could go back and give themselves that opportunity, I would start off by doing it. The second one is I have not seen a lot of information or a lot of discussion around the education I think that is going to be needed for the NCOs and the providers, for consumers, for counties. I just think they should start a very aggressive education program and as many venues as they possibly can as soon as possible. As much as possible, I would use consumers as teachers, and I would use people who use the services as teachers. I would use professionals who have studied this as teachers, but I would miss an opportunity right now to start that education, a fairly aggressive education program as to what does long-term managed care services and supports really mean at an operational level. I mean, right now we're still at a theoretical level with a white paper that I thought was good, but we now need to have a much different understanding as it begins, so that the RFP can be understood, and we can understand what's there and what's missing. I think the state needs to define a little bit more clearly than they have what I call what success looks like. In other words, if the plan is implemented as their vision, what does it look like? What does a successful implementation of this really look like? What does it look like in the urban area like Philadelphia? What does it look like in rural areas as you get into mid-state? And what does it look like in the more, in other less populated areas of the state? But what does success really look like? And how would we define it when we're there? The other part of the plan that, and I don't believe I saw this either, I would have a very strong discussion around housing alternatives. One of the reasons people ended up in nursing facilities was because they had nowhere to live. It wasn't that, the whole world isn't diabolical and wants to lock people into institutions. Sometimes it's a very basic, where are you going to live? And I think there needs to be a housing planning, a housing alternative plan, that I happen to know the state's working on one, but I think it goes hand in hand with this. That if we really want to look for alternatives institutions, we have to have a plan around how do we keep people from being in institutions because there's alternative housing. A couple of the caveats I would recommend to the state as they move forward. I'm sorry, one last remaining question. I would say they need to look very, very closely and carefully around the carve-out of behavioral health. I'm not going to make a recommendation here, but I am going to say that the state needs to take a very hard look about not only the immediate gains, but the long-term issues as related to the carve-out. For caveats, I would say what I mentioned before was do no harm. Whatever we come up with and have implemented, I think we want to be very careful that we do no harm. That people who are in plans, people who are, quote, thriving in what's happening now, we should permit them to continue in that plan, even if there are some flaws in it. Mm-hmm. But understanding that those flaws will probably be assumed over time. I would not disrupt a person's life right now. I would do no harm. I would always, as a fallback, when given choice, wouldn't give an opportunity to listen to consumers first. I think that when you come up to a question about whether you should or shouldn't, or what is good for a population, or what is good for people, I would listen to consumers first, and help make the decision. I would be very careful to listen to family caregivers and parents as we move through this, because they are our baseline system right now. When no one else is there very frequently, the families are there, and they go a mile. I'm talking about an overloaded group. Our case managers are overloaded, but nothing is overloaded as many of the families are, and many of the caregivers. And I would never lose my focus on quality of life. So I would say, in summary, the caveats are: do no harm, listen to people who use services, focus on quality of life, and when facing a dilemma, listen to the consumer.
All right. Well, I'm gonna talk through the recommendations that the PDSS Coalition is planning to submit tomorrow. And then we'll do a few things by way of closure. We've got just a few minutes left here. So there are 7 recommendations that our coalition is planning to make. The first is that we ensure that person-driven options are available for all LTSS participants. So recommending first that MCOs have to reach some kind of benchmarks or enrollment targets for participants using self-directed options. So not just that the benefits package allows for self-direction of services or person direction or consumer employer, but that MCOs are actually held to some kind of standard for expectations around how many people are using those options. Currently, I believe if you look at all of the OLTL waivers, so including aging and ComCare independence, attendant care, roughly 35% of people statewide are self-directing at least one service. So we want to make sure that the MCOs are incentivized to be enrolling people in self-direction. The second piece of that is ensuring that people who want to self-direct have the support to do that, so that there are professionals out there who really understand the ins and outs of managing your own employees, of managing an individual budget, of how you can combine both agency services and self-directed services. So again, we're fans of the support broker model, and want to make sure that people who need that additional support to self-direct have that. For many people, that might be a temporary service while they're getting people in, hiring them, and once they've got fully staffed, then maybe they're not using a support broker. But either way, that is an option that people have to have that additional assistance to self-direct. Our second recommendation is to include a cash and counseling option in the benefit package, so that again people have the availability of that individual budget, and they can use it to purchase the goods and services that they need in the most flexible way possible. We have some specific recommendations, sort of reflecting on Services My Way and how that's done currently and how that could be done better. So I'm not going to get into that detail, but I will send these comments out so everybody can look at them if you want that kind of detail. Our third recommendation is that the plan include a self-directed care option in the behavioral health component. So right now in our behavioral health care system, people do not have any option for self-direction of those services. We have in Delaware County, there is a demonstration project that's gone on for a number of years called the Consumer Recovery Investment Fund, where people have an option to self-direct some of their behavioral health. We like that model very much. Our coalition does. We support that model and believe that that could be pulled into any kind of new system that's being developed. Again, I won't get into the full details of what that looks like. I will make this available, but we are encouraging the DHS to use, if we're doing sort of a system overhaul at this point, to use that opportunity to add self-directed care options into behavioral health as well. Our fourth recommendation is to encourage innovative uses of technology, so to include in the benefit package things like smart home technology or telecare, personal emergency response systems, so to really not limit that and allow that benefit package to be pretty broad and take advantage of some of the amazing technology that we have, so that people can live more independently, and where sometimes people might be reliant on a person when they could actually use technology to do that same thing. So include that in the benefit package. Our fifth recommendation is to ensure intensive training for supports coordination and to have some very clear role distinctions between what are the responsibilities of the MCO, what are the responsibilities of the supports coordinator, if there are support brokers involved, what are their responsibilities for the financial management service provider. So to have those roles really distinguished clearly up front, and so that there isn't confusion and some of those responsibilities don't get dropped in that confusion. That recommendation is based on research from other states. There are a number of other states that have participant direct options in their managed care systems, and that is a lesson learned from a number of those, from research on those. The sixth recommendation is that the ratio for service coordinators is appropriate to really allow for, so the ratio of service coordinator to people they serve really allows for that intensive service coordination and person-centered planning, so that we don't sort of replicate the system we have now, where service coordination tends to be overburdened and not able to really respond to the needs as people would like. The seventh recommendation is to ensure that stakeholders are involved and that there is transparency at all levels of design and implementation. So from DHS taking these comments now from stakeholders, this shouldn't end here. Our recommendation is that people are involved at all levels of design and implementation, including adoption of financing and service delivery changes, the concept development, the contract specifications. So the RFP, when that RFP should come out in draft, people should be able to comment on that. That any kind of contracts and contract requirements, all of that stuff, there should be heavy involvement of people who are actually going to be using the system, and that's echoing what Estelle said a few minutes ago. So those are our recommendations. With that, I want to thank Estelle for sharing your broad perspective and your knowledge and your expertise with us. This has been very helpful, and we appreciate the conversation. For the questions that we didn't get to all of the questions, what we'll do, and we did this last time with the presentation that David Gates did, is we took those back, answered them, and those answers, the questions and answers, are posted on the project webpage, which I put up on the screen, and I will send out with a follow-up email. We'll try to do the same thing with all the questions that were left unanswered today.